you just make the key intervention that would change the whole thing. This is one of the things I really enjoyed about that. I think, we're both important that I was doing the sort of talking around that got the family to that point, and then you saw what was really the key and brought that out. Sometimes I do the same thing, but I think you do that more than I do.
Yeah. It's one of the things that I found, from my point of view, working with you, was that your ability that I had an idea that may have been half-baked, as it were, and I would come in with it, and you were able to perceive what it was that I was trying to do, sometimes understand better than me what I was trying to do, so that helped me to develop it, take it further.
Yes, I recognize that.
Yeah. Or put it better. Very often, even just on that level, that I was struggling with the formulation of the idea.
And just being a throw in it, must you?
That, yes. I think I know that you don't like this question, but I'll still ask you. What about books that were important to you and important to your development?
Yeah. The sort of outstanding two books I expect are the Mnuchin's Structural Family Therapy and the Palo Alto thing on change, which sort of started me up on these. My latest sort of thinking, even though it was in opposition to what they were saying, because they didn't seem to get the point, those were two important books. A book by Flugel called 100 Years in Psychology was very important because I passed psychology for the DPM in that, and just after it was the first thing I did after getting out of the army. That and The Ego and the Id by Freud, which I read which was about the only psychiatric book I was able to get hold of in the army. And so for the psychology exam for the DPM, one of the questions was what books have been most influential, which is probably why many people thought about answering this question.
Right.
Because the only two books I'd read were Flugel and The Ego and the Id, which made a very good pair, you see.
Yes, I remember actually, I read Flugel, it just came back to me, because I haven't heard anybody talk about Flugel for a long time.
Yes, throwing out old books, he was the one that was tossing up both them out. So there are those three, but mostly I think I've got most out of journal articles. I think by the time the ideas get sort of consolidated into a book, it sort of seems to have lots of flexibility and its sort of liveliness. You get being an eclectic thinker, I like to sort of find some useful concept and build it into the theory I've got already, so that we've got a whole book, he's got a whole set theory, and I can't build a whole book into my own thinking, so it's like this is one thing. So I still would be taking bits out of that book. See, Mnuchin's book is a different kettle of fish because it's the amount of theory in it is not very great, but it's a beautiful combination of a theoretical exposition and practical illustrations, which we can integrate quite nicely.
You're an integrated eclectic, if there is such a term, rather than one that just sort of has a whole collection of ideas from everywhere that sort of to suit the moment. And if that's the case, who do you think are some of the major ideas and theories that sort of make your own eclectic position?
That's a fairly easy one, I think, because it's sort of it's the stream that's run through the clinic activity. I think without putting it in any order of importance, I think the sort of experiential, existential concepts with sort of the Gestalt people at the active, sort of more superficial end of that, and some of the existentialist writers at the other end. sort of read a bit of. Then, I'll not take too long over that one. Object relations stuff, Fairbairn and Guntrip, which I've been keen on for many years.
Yes, I guess one of the reasons behind that question was because I lost throughout the hour or so that we've been talking. Guntrip and Fairbairn haven't featured yet, and I was wondering what happened to them, whether they have died for you, as it were, or they're still there.
That's right. Well, they're of course not people so much from me. I haven't met either of them, and again the sort of the concepts have been very useful and important for me. I've sort of developed them in my own way, and I think I need to go back to the source every now and then. I think right from the start, I differed from them in quite significant aspects, and so I've sort of developed their ideas to suit myself rather than without worrying whether how orthodox a version of Fairbairn they were. But Fairbairn's theories of the personality, I think, isn't it, was a book I really enjoyed reading, and Guntrip's later more compendious one was one that was useful for me. But yeah, that was that and a few articles on the talking about it that's been useful there. So we've got the experiential bit, we've got the object relations bit, the sort of underlying Freudian thing that we all have, I think, with the ego mechanisms particularly, defense mechanisms. It sort of goes in with the object relations bit, but it's a separate area. The Minuchin's work, structural family therapy, the concepts of change and paradox from Palo Alto, and Haley.
The whole communication theory then.
Yeah, that's right. From yes, aspect communication theory is fair enough. The main bits, I think,
Changing the subject again, Jeff. I want to talk to you at some length maybe about your actual work with patients and with families and so on. Maybe I'll start with something that I think is very, very striking when I think about it, and that is that in the years of practice that you've had, I believe that you've never had one patient who successfully committed suicide. And for that matter, homicide, I presume.
That's right.
And that on talking to you, I also know that you have not selected patients who were bad risks, as it were. You know, that patients who are or sort of suicidal or homicidal are not patients that you ever excluded from seeing. And if that's the case, I wonder how you sort of account for that. Because I'm proposing that it's a very remarkable record.
Unusual anyhow, yes, I gather. Yes, certainly there's been no selection. I don't think it's sort of widely known that this is that I'm good with suicides or anything, but I certainly so they don't send me.
Don't know if you're good, but you're safe with it.
Yeah, that's right. They don't especially send me these people, but I certainly get a lot of depressed patients who have made suicidal attempts and so on.
Whilst they may not send you these sort of patients, it is also true probably that you get a fair proportion of patients who other people have worked with and have failed and therefore send them to you.
Yeah. Yes, quite a number. So that, I think the selection hasn't been a factor. And I don't know what it is, but my hunch about it is that, from early in the piece, I've been pretty comfortable at working with feelings that when patients express a good deal of fear or in the grip of their feelings, I'm pretty comfortable. I like that to happen. I sort of rather welcome it, so that I don't encourage them to push their feelings away, so they're not so controlled by them. As a result of that, there's no doubt that there's a virtuous spiral effect after 10 or 15 years and nobody's suicided. You know yourself that they're not going to, and so I think my response becomes very confident and accepting. So if somebody talks about being suicidal, it's easy to get across a sort of...
Let me go back to your first point, Jeff, because that's a very interesting one. You were saying that the first thing that you mentioned was that you feel very comfortable with patients' feeling, and consequently you allow them a full, possibly, expression of their own feelings.
Yeah.
Why I'm so interested in that is because many people would think that one of the dangers of doing psychotherapy that would lead to suicide is taking a patient who is precarious and pushing him further, and that is that you interfere with his defensive structure, as it were, and when you allow him or encourage him to express feeling even more, that in fact you're pushing that bit that in fact would lead to suicide, and you are attributing possibly to the opposite.
Right, yeah. There are some that would say you neither allow nor encourage. I don't. With a person who is liable to be depressed and suicidal, I really work by confrontation, but allowing is more the thing.
Because a common theory...
Enabling them to experience their feeling fully is the thing, I think.
Right. Rather than it is thought by some...
Sometimes I'm confronting, yeah, go on.
But the thought about to make it mentally, in terms of mental health, safe, that you should be sensitive to the possibility that there is, say, psychosis there. And if that's the case, then to presumably defend the patient against the full expression of their feelings. Yeah. It's a very common theory.
Very common, yes, and because it works in reverse. I'm sure this is why some therapists get suicides, because they get careful.
Right.
And it's partly because they're worried about the medical legal aspect of it. Mm-hmm. And this is where the virtuous spiral comes in. I know it's not going to happen, so I don't need to do that. Right. But I think the same goes with working with psychotics too, that if you can use the... although I do think sort of being psychotic is not a sort of a distressful and unhealthy state, if you like. I think that the productions of the psychotic person can be used very positively in therapy, just like dreams can, and that's the way I work with them. So I think that's useful too. It helps them to come back to reality.
And the way you talk about it, you're obviously not that concerned about making a patient psychotic. That is to push him into a psychotic situation.
What I'm hopefully sensitive to is the little bits of little niggles of feeling, like with a suicidal person, little niggles of feeling that he's so that shows that the feeling is there, but he can easily take them away. And I'll be sensitive to that and encourage him to come out with this. And the same thing with the psychotic person, the odd little bizarre idea. We'll try and bring it open and out in the open and use it in what I'm doing, what we're working on.
Which many would argue the prescription for inducing psychosis, not...
Yeah.
Mm-hmm. The other thing that you told me you do is you encourage patient, or if not encourage, you let them have your telephone number at home and they could ring you at any time.
Yeah. Yeah, I think it has been useful and it has been important on a few occasions. They've had that. They have rung up in quite a distressed state, and I don't enjoy doing therapy on the phone. I don't find it. I'm good at that. But where a patient really is in a distressed thing, I can do that pretty well. The odd hysteric personality that will go on the phone. I don't find myself working terribly well there, but nevertheless it's necessary for them to have that, and they very rarely abuse it.
When you say very rarely, how often?
Well, I guess one of my own patients wouldn't ring me more than I wouldn't be rung by one of my own patients more than once in 3-4 weeks.
That's during the day or night?
Well, that's at home, I mean.
Yeah, in the middle of the night, or
Oh,
to me there's a big difference between a patient ringing you at 7 or 8 o'clock in the evening, or 3 o'clock in the morning.
I'd say not more than once in 6 months would be after I get to bed.
Mhm.
Perhaps a little bit more than that. I have to go to bed to answer it, but
Mhm.
certainly not very much more.
Mhm.
Certainly not enough to be a worry to make me regret I've done it. And I've told them.
Mhm.
And again, it's more other people's patients that ring me, or patients who get my name out, number out of the book that I get those calls from.
You mean people who are not your patients at all?
Yeah.
And some of these are people who are patients of other members of staff in the clinic, you mean?
Some of them, yes,
Yeah.
yes. Because my names were in the front page of the book, you see.
Mhm.
After hours number of the clinic.
So that on the whole you're saying that it may have been one of the holding thing for patients to have your telephone number and knowing that they can ring you and occasionally doing it. But from your point of view, it really hasn't interfered with your life.
Till now. I quite enjoy it, actually. Occasionally.
Okay. Most therapists, in fact, find, Jeff, that they learn more from their patients, possibly, than from anybody else. Or if not, at least usually have one or two or a number of patients who have been very significant to them and have taught them a great deal of what they know. Have you had this experience too?
Yeah, yes, undoubtedly. Yeah. I wish it were true that I learned from all my patients from every interview. And I think it's in fact a good criterion of whether the interview's gone well as to whether I've also learned from it. Ones that go well, I haven't learned much from usually. And but I speak the one outstanding patient for me is the case of multiple personality. Partly because over the years I've seen such changes in her, but particularly I think because he sort of caricaturises psychodynamics, that this ability to dissociate sort of brings the various mechanisms that go on and the sort of powerful stuff that goes on in the unconscious. She's able to give a very clear picture of this, and it's really quite a fascinating process to see this at work.
Mm-hmm.
And fits in beautifully with the work on object relations and so on. And she's a family in herself, of course, but they're not really. She's mainly a lot of siblings. So she's been important for me as well as being a rather, charming person too. A schizophrenic woman that I worked with, the one I presented to that psychotherapy group I mentioned earlier, who had a very horrific childhood in camps of various sorts in the Baltic countries, with the war going across the top of them every now and then, and she was schizophrenic, but she had a lot of humour and personality and courage and very interesting personality, very aggressive. She'd slash train seats with the fences. They were her young sister and so on. A lot of this stuff. In fact, she produced a knife one day, and from her bag she always carried a long carving knife, packed of razor blades and 50 phenobarbs, so that when she had the guts to, she'd and she produced this long knife from her skirt, pulled out this and started going slash, you see. And I was sitting here like this very calmly and saying, you're feeling angry with me, are you? And saying, I'm actually feeling afraid when you do that. Mm-hmm. And then she got lower and lower at my hand. I just flipped my finger up like that, just a tiny little bit, and she just caught the top of it with her knife. And she immediately changed. She saw the blood, you see, and she was apologetic, and she was saying, oh, I'm sorry, I didn't mean to do that. It's a fascinating experience. But she was the one I read a lot about the sort of mechanism of schizophrenia, I think.
Mm-hmm. And I guess if you sat through that interview as calmly as you described, after that you could sit calmly through maybe any interview.
It was not like calm inside, yes.
Mm-hmm.
What else? Some of my depressed ladies have been. I've learned a lot about depression. depression, particularly a couple, or one lady that I've dealt with on a rather like Kempler did in that paper of his with the depressed man, where she was really stuck in this terrible depression. It was really giving her hell, and I decided that my guess was that there was a sort of punitive maternal introject, and so I really got punitive about this maternal introject, and I really was attacking that and sort of differentiating from the hostile maternal introject between that and the person herself, and that the dramatic effect of that sort of I'll learn more about the domestic relations thing, because that one session seemed to make 6 months difference.
It's interesting that the people you have mentioned today, or patients that you've mentioned today, have all been individuals.
Yes.
What about families?
Yeah. Well, it's interesting you should say that, because I think it's true that most of my professional career has been with individuals. See, it's only really in the last 8 years I've been working with families. That's one thing. And the other thing is that I don't get as intimate with any particular member of the family as I do with an individual patient. Another thing is that it's much quicker. So, there's only the odd family that I would have more than a dozen, 15 interviews with. Whereas the individuals, they may go on for 3 or 4 years, especially in the earlier days. But
it raises.
I think I'm in a reminiscent phase at the moment in this interview. You see, and so I'm thinking back on those days, and the recent events of the family work doesn't get triggered up so easily. Because there's some families that have been very important to me, there's no doubt.
Nonetheless, it is interesting whether, in fact, individual work with the intensity that it produces, and with often the fact that it goes so much longer, that individual therapists learn more from their patients than family therapists. In other words, I wonder if a family therapist of 33 years duration was to ask the same question, what his response would be.
Yeah, interesting. You certainly learn more about systems and more about how people interact, but do you learn more about people, such? Well, obviously that's not an answerable question, is it?
Well, we're getting towards the end of the interview, Jeff. Just wanted to ask you about your plans for the future.
5 months overseas, where I have to both see a lot of old new and enjoyable things, as well as doing some interesting work with people, and then come back and I have about half-time private practice, and I have to maintain contact with the training in family therapy and with supervision. I think there's a lot of things I'd like to do in family therapy training still that we've only just played with so far. We've done a little bit of so far. And if I have more time to think about what I'm doing, I hope your plans of getting your training scheme going will come out, and I'll be able to help you with that. That's the work side. Then I have to enjoy my leisure too. Lake Tyers, I do all that, and sailing and all those nice things. And I do also hope that with the bit of extra time in my hand, if I am able to keep to the half-time, working time, as it were, that I'll be able to go around and visit places and have lunch with people and make more personal contacts than I've been able to in the past. So I'm really looking forward to it.
Oh, beautiful. Well, all the best.
Thanks, Marcia, and thank you for asking me such evocative questions.
Thank you. Music!